Thanks.
All right. Good afternoon, everyone. Welcome to the CTSI Academy Enrichment series. Today's topic is basics of research billing and compliance. So this was highly requested, and we have a great team here representing both Freighted as well as MCW sites and children's as well. So I will let them introduce themselves, and we will go from there.
Sounds good.
And Teresa is a little out of focus,
Okay. I'm here, don't worry about it.
but feel free to introduce yourself. So,
Yeah.
Go first.
I am Amber Collier. I am on the MCW side for professional billing, and
I'm Betsy Polak. I'm the manager for Freighter's Oak Creek department.
Hi there, Laura Held, CPS for MCW Professional Billing.
I'm Teresa over here on the side that you can't see, but I'm the Director of Clinical Research Operations at Children's, and I'm just here to answer any questions that might come up related to pediatric and billing.
Yeah, great. And we're glad to be here today. We're here, as Amit said, to talk about basics of research billing compliance at F&MCW. So just a quick overview kind of how our programs are set up. So Freighter Oak Creek has, a director, manager, myself, and 9 nurse consultants and 8 billing specialists to help support all of that operational and financial feasibility work that we do for all studies that impact our Freighter patients, staff, environment. And we've been in place for the hospital system since 2008. So going on almost 20 years, gosh. So excellent. We're glad to be here today. We've got our professional research billing colleagues next to me who introduce themselves. We've got Laura and Amber, and then you guys have one more team member who's not
Yes,
here, right? Brooke.
Yep.
And do you just want to give a little quick background of
Brooke's role.
Brooke's role?
Yeah. So Brooke, she does the professional billing. She is actually the one that is processing the charges for
Okay.
research.
All
Yeah.
right. So you guys are helping her
Yes, correct.
manage all that process, but she's actually the one who's doing the
She's
work.
the one doing the work.
All right.
Yeah.
We're looking to get more help.
So today's objectives really, 3 main ones. We want to make sure we provide kind of a good overview of the basics of billing in the context of a qualifying clinical trial. And then what qualifies as study related, right? And those terminologies that we talk about, standard of care or S, right? And research paid or R. And then both Freighter Oak Creek and MCW CPS, billing compliance workflows just highlight some of the key pieces that you guys need to remember as coordinators and support staff for research at our enterprise. So starting with research related financial impact, just going over what does this mean? So this really is related to study related billing, right? So hospital or professional billing that is at the patient level. So coming out of our Freighter Epic, whether that's something that is what patients have every day, or is something that is solely being done for research, whether it's being billed as standard of care or whether it's being paid for by the study. Those are all of the charges and pieces of this crazy puzzle that we from CPS and from Oak Creek need to make sure we have a good understanding of how those charges are going to be routed. And that's because of, high level regulatory things that we'll get to in the next couple of slides. And so, those things that are billing insurance as a routine care cost in the context of research, they have to be billed out of our organization correctly, because if they're not, they will get denied, or we will have problems getting those services covered for your patients. And it just creates a lot of work on the back end that we don't want to have to deal with. So we try to do a good job up front, getting that financial plan in place alongside your teams for every study, every patient, every time. And so on top of that, if your studies provided services for free to that patient participant, they've signed a consent, right, that says you're going to pay for that. We want to make sure, right, that we're covering those as well, and ensuring that those don't get billed to that patient participant and that they're correctly invoiced to the study. And so some projects have both. Some projects only have research. Some projects only have clinical care services. And each project is different, and we do a complete review for each project so that we can define that financial plan behind the scenes and manage our claims accordingly once you start enrolling patients. So research billing basics, what qualifies as standard of care? So the two big things that we want our research coordinators to remember about standard of care billing in a qualifying clinical trial is, number one, is it required for the provision of the investigational item or service? For example, if you've got an investigational drug and they need to administer it via, a central line. Those services are considered medically reasonable and necessary for that treatment to occur. Even though the investigational item or service is provision free and it's not something that they would routinely get, in the context of a qualifying clinical trial, the gold standard from a coverage perspective is to bill those things. And is it considered medically reasonable and necessary for things like monitoring, treatment, prevention of complications? And you'll hear us and see in our coverage analyses refer to that NCD 310.1 routine care costs in clinical trials linked in our presentation that I'm sure Amit will share after this presentation for you all if you need access to it again. But again, it's that concept of participating in clinical research. It is care and treatment that is also research in most cases. And it's often requiring some additional things or things that they may not actually have performed for their treatment or care outside of the context of research. But because it's considered medically reasonable and necessary for that monitoring, treatment, or prevention of complications in the context of the trial, it allows us that broadened coverage to say, yes, that is billable as routine care in the context of a qualifying clinical trial. And so that's something that's kind of critical for you to understand about why we do what we do behind the scenes. So going into some examples, that first one that we just talked about, right? Administration of the investigational product. Why is it billable? It's provisioning the investigational item or service. It's that industry standard supported practice. Most entities like ours have policies in place where they don't allow sponsors to pay for the administration of investigational drugs. They standardly bill for those services as a routine care in the context of a qualifying clinical trial. And that's what you'll hear us reinforce with you as part of that project planning is when it's billable, let's bill it. And administration of the investigational product is one of those things that we want to be billing when we can, and we do. Hundreds of patients a day have investigational drugs or drugs administered in the context of a qualifying clinical trial, and we are billing those to their insurers, to Medicare, and those things are being covered. But we rarely see, if ever, a denial with this kind of a situation.
So there's a question.
Sure.
Can I interrupt? Are nurse consultants assigned to specific departments or areas of study? How
Yes.
do you determine what nurse consultant is assigned to a project?
So we do have research divisional assignments structure in our office. We kind of have an oncology versus non-oncology with a couple of nurse consultants who straddle both areas, but that's really based on metrics. It's based on how many studies we get a year, and then it's based on their areas of expertise and which divisions they have that background from a clinical aspect to support. And so hopefully that answers your question. If not, just throw another one in the chat or unmute yourself and ask. Anything else in that chat?
She says,
Okay.
thank you.
Great. All right. So next example, safety labs or procedures. Why is this billable, right? So we're talking about your basic chemistry panels, your, tumor markers, your thyroid testing for things that have endocrine impact, your cardiac testing for drugs that have cardiac risks associated to them, your lumbar punctures for, safety reasons to make sure that that patient doesn't have something awful going on behind the scenes because of the research that they're participating in or the drug that they're receiving. All of these services fall under that monitoring, treatment, or prevention of complications NCD. And so how we do our coverage analysis is really, we first are looking at those items and services in the context of the qualifying clinical trial and saying, is it clinically relevant? Is it medically reasonable and necessary to do this based on how that protocol outlines things, how that ICF identifies risks? And then we're looking at, is there any other NCD or LCD, right? So national coverage or local coverage determination that really limits or prohibits that item or service for that patient population. So sometimes there are those service-specific coverage rules that apply. And usually what we'll try to do is if we're not finding something for that primary diagnosis that the study is investigating, we'll work with you and speak with your investigators to say, is there a secondary diagnosis that we're not thinking of, that because this patient has this disease, they also end up having these typical, additional diagnoses, or would almost always have this thing occur. And so it's reasonable, clinically reasonable to do this service, to treat them or to monitor them or to prevent any of these typical complications that come from this type of treatment path or this patient population. So this is why that coverage analysis is key, right? Because just because your sponsor wants to pay for it doesn't mean that that's the best use of the money that's coming in for you. You can move that money to another bucket of your pot because they don't necessarily have to pay for that thing that is really truly being done for that safety reason. And again, this is just another situation where F&MCW regularly bills for, right? We regularly bill for labs and procedures that are clinically relevant safety testing to patients and insurance in the context of a qualifying clinical trial. So this isn't new to our organization, and it's work that we do all the time. It just we are those experts, and we want you guys to rely on our expertise to know we're not just, right, like telling you don't let them pay for it. There's a reason behind it. So the last example, or the second to last example, is a surgical procedure for use or implant of an investigational product like an IDE. Same concepts apply really, as we talked about in the last slide. Is it needed for that provision of the investigational item or service? Well, you can't implant the cardiac valve if they don't have the surgery in the first place. And so those things, again, we're billing for routinely in the context of a qualifying clinical trial. Now, there are, again, service-specific coverage rules that may apply, and we've seen that come up a time or two with different devices or different diseases, but it's really not often that happens. And that's why that coverage analysis is key, and we'll communicate and tell you that if there's something that comes up. But we do regularly bill for those surgical procedures for implanting an investigational device or use of an investigational device for that kind of a treatment path. And then lastly, hospitalization. Why is this billable if a patient wouldn't need an inpatient stay outside of the study? And it goes back to what we've talked about, right? Clinically indicated monitoring, treatment, or prevention of complications. So while again, there may be some service-specific coverage rules that apply, right? Admitting a patient for stem cell transplant for a disease that is inherently not covered, then sponsor's going to have to pay, right? But in most cases, that hospitalization is going to be needed because there's a significant risk associated, or it's the typical treatment path for that kind of patient population, and we're just needing to have that inpatient stay to be able to appropriately monitor them or appropriately treat them. And all of those pieces, again, we're billing to patient insurance in the context of a qualifying clinical trial here. So study-related costs, it's really coming down to that study relatedness, that location of service, and that identification of those pieces during our grid preparation, right? And that operational feasibility tool is one of those tools that's been around for a long time that helps us identify the who, what, and where, so that we know Is it freighted or MCW space? Is it a freighted or MCW service? Or is it not something that's related to any chargeable events in Epic at all? Or is it happening in a service area that isn't tied to Epic at all? All of those things and the collaborative front end work that we're doing to try to get that calendar build accurate is that needing that good understanding. And so that's really what we need from our study teams, right? Is that you have as best of an understanding as you can get on the front end about what the plan is, the who, what, where. And so services in the context of a qualifying clinical trial, whether they're research paid or standard of care, if they're required by that protocol, they're considered study related. So that's one important thing that I think gets mixed up from time to time is that, well, regardless of billing disposition, they're all study related services. And that's where some of that confusion sometimes comes in. Is it standard of care from a billing compliance perspective? Is it standard of care from an operations perspective? And that can kind of get mixed up a little bit. And so when we're asking our questions and asking you to be specific when we're trying to get that clarity, it's really for a reason. And it's to facilitate that accurate financial plan on the front end, so we don't have any problems with billing compliance on the back end. So just remember to just be as detailed as you can when working with us, and please don't get offended when we ask questions or try to seek clarification, because it's really in the best interest of your participants and your budget. Couple of those recurring points of confusion is, right, research related adverse events and emergency treatment. You know, we encourage you to review that D5 informed consent language and making sure that you have a good understanding of how our organization approaches that research related injury. And it's really that we are going to bill those services to patient insurance. And on the back end, MCW IRB, sponsor, provider, study team, if there's a true subject injury, that determination is going to be made outside of the normal billing workflows that OCRIC and CPS oversee. And any kind of patient reimbursement would be determined on the back end. We can't bill differently for one patient versus another, which is why that financial plan build on the front end is so important. Another recurring point of confusion is the misunderstanding of study related costs. And sometimes that can happen, you know, provider to patient. And so it's really important that, you know, you engage your PIs in good discussion, that they know if they aren't sure whether or not the study has provisioned something for free to a patient, they really shouldn't just say all your study related costs should be covered. They really want to redirect to the coordinator staff or to the financial staff on your team to ensure that they're not telling a patient that everything's covered when the reality is it's not. We've had some of those situations happen in the last couple of years where then that financial burden of that conversation ends up falling to the department or the division because something was said that wasn't true. So, and all of these activities, right, when we're not doing as good of planning up front, it ends up taking time and attention away from that next study's activation works. And so we want to make sure that these conversations are had, and this is one of those areas where it's really important that study teams have good processes in place and good conversation mechanisms between them and communication between them, their providers, and their participants. So the last one, or the second to last one we want to talk about here is my chart check-in. And so this is something that was recently communicated, education provided through the Research Pulse about how to educate your patients on when they're using my chart check-in to not mark do not bill insurance when they, as a placeholder for the study's going to pay for my service. They really need to be using that use insurance button, because in the system, if they say do not bill insurance, then those charges aren't gonna route to us for review, and it's gonna cause a whole big, ugly, messy thing with your patient where they're going to get a self-pay bill and they're gonna be approached by our patient financial services to cover the cost for something that we know and they know is gonna be paid for by the study. And so this is one of those things that has come up recently that we're trying to provide some additional education about, because we don't want patients feeling that heat, right? Especially when we all know the appropriate financial plan is in place. It's the system limitation, unfortunately. So if you have questions about that, or if you have patients who come through and say, I got this self-pay estimate, what do I do with it? The likelihood is that they probably did this. And so we may need to do some investigation, but you can always talk to your patient about this in advance, especially as you're working with them to get them coordinated for their first visits. It's a good reminder. Anything else on that,
I see there
Laura,
was a
or-
question. Yeah.
Okay.
How many studies or what types of studies typically use my chart?
Well, I can answer
Yeah.
that. So what we're seeing is when they're doing a check-in for their, usually a radiology service or some kind of a procedure that is an appointment in Epic, it will come to them to do a MyChart check-in. And that's when they're doing this process. That's
Yeah.
the screenshot of what they would see, and it's highlighted use insurance. And you should talk to them about that to make sure they are confident that even though they're saying use insurance, if it's the study service, we will process that appropriately.
Mhm. Anything else to share?
Nope.
Great. Next and last recurring point of confusion comes to service area, right? So research related lab collections. We have a couple of different options at our site. We have WDL external client, and then we have our freighter clinical WDL services. And so just highlighting the difference between those and the importance to just really call that out. And I see I left a little bit on that bottom, often less costly. But basically the situation is when you are identifying which service that you're using, because you are going to know, right? If you're coordinating with Eric Gifford and WDL external client and getting your life point or your paper requisition or any of those things in place, you are using WDL external client. You're not planning to order that lab in Epic. And so that's really important to us so that we know how to build your grid and what charges to anticipate. And so that's really where we want to make sure that you guys are clear. And when you're clearly communicating to us, just please don't say WDL, because that doesn't mean anything to us. We're always going to come back and ask you, are you saying WDL external client, or are you saying freighter WDL clinical workflow? And I do know also that there is a way for LifePoint to have those results for that WDL external client path in Epic. We just know that that's not the typical way, because when you're using WDL external client, you're using them really usually to help with like processing or to manage those kinds of labs that don't belong in the medical record. But anytime, if it's easier for your patients, if it's easier for you as a coordinator to manage just following the normal clinical ordering workflow, there's no problem with you doing it and requesting that pricing and having it managed through Okrick versus using those WDL external client resources. We just need to know which one you're using. Kelly, I see your question. You would definitely use the freighter WDL if your patient was being treated in freighter, right? They were having their procedures, and these are safety labs that they're going to be, right? That's clinically appropriate monitoring that's going to be helpful for our clinicians to see if there's an issue or a problem that would come up that would require that patient to come in. That doesn't mean you have to, but that's in my mind as a clinical, right, background nurse, it seems most appropriate to use those freighter resources when there's value, clinical value to having that result in their clinical record. And in most cases, the research that we're doing is research that is also care and treatment. So it's it's important for it to be there as well. Can you use WDL external client in those ways? Yes. And some departments and divisions really want to use WDL external client for whatever reason. And that's fine too. I'd recommend just reviewing internally with your team. What is the usual typical resource that you use? But if we're talking about an investigational new drug or a investigational device, and those are safety labs and all of that care and treatment, that's also research is happening in the clinical space, I would say you have your labs route through the clinical as well. And if that patient is being cared for in our inpatient unit, or those services are standard of care and they're happening in Freighter, the Freighter clinical space, that's what's going to be used. And so that is also how you would know, is that location of care. I hope that answered your question. I know it's not always the easiest. But if you have any other questions, please just don't hesitate to reach out to us after the fact and we can help. So just a quick slide, high-level review of our OCRC review and approval process is, right, that project's logged. It's assigned for operational and financial feasibility review. There's a nurse consultant and a billing specialist dyad team who support those research divisions like we talked about. That initial review is completed, the financial plans developed, any remaining operational feasibility planning is facilitated, and our administrative approval is authored. And this is done for each individual project. And just because something was approved a certain way in your project 2 years ago doesn't mean that it's going to be able to be accommodated exactly that same way current state. And that is why we review each study of its own merit, because things change easily in our environment. And we don't want to assume that something is doable when it may not be. And then pre-approval, right? We have our billing grid developed. We work with you on issuing pricing and any other coverage analysis needs. And so we've got kind of these two situations. We've either got a formal Medicare coverage analysis when there's standard of care qualifying clinical trial billing involved, or we've got what we call a study invoicing grid. And that's when everything's research paid and there's no qualifying clinical trial billing involvement. And we will identify that current state in Encore financials. You'll see that in the comments page on the QCT tab. And then that will be pulled out in that Excel spreadsheet document, that final agreed upon plan in the first tab. You'll see that there as well. And then also the naming of the financial plan. We do say either MCA or SIG on that as well. And then we do also issue a pricing sheet. We know that we've got a research charge master and the Encore financials charge master, but we do issue a formal pricing sheet for every project. It helps our billing specialist when it comes to invoicing as well. After the approval, right, we rely on that study association, CPSs as well, right? If your patient isn't associated, none of those charges are going to come to us for review. But once they are associated to that study, all those charges, whether they're research related or not, come to us for review. And that's why we need that financial plan and those notifications, because we perform that 100% claims review, every charge, every patient, every study. And we make that discernment. Is it going to bill as routine care? Is it going to be paid for by the study, or is it not study related? And those are just a couple numbers about what we're currently managing, as far as claims management through our office. And then invoicing, this is just a little bit more about billing, and I skipped ahead. So I already explained all this, so I'm gonna skip it. Post-approval, right? Invoicing. So services that you had in February are gonna be invoiced in March. Services that you had in March are gonna be invoiced in the next month, right? So we do between 180 to 100 invoices a month, but it's highly variable, the amounts, right? And so it just really depends on what services your participants are having and what's being paid for by the study. And invoices on the MCW side are now being followed a little bit more closely. We've been working very closely with Eddie Rain and Colleen Cultus from MCW Accounts Payable to just get a little bit better turnaround on payments for that. So if you have any questions about your invoice, sooner rather than later is the best time to tell us, because we know you guys also have timelines for grant funds or other things that if we don't meet that timeline, you could have a problem. So look at those invoices, make sure you're evaluating them in a timely manner and getting back to us in a timely manner so we can get any errors or corrections made, or we can clarify for you things that might not be clear. And with that, any other questions, just shoot them in the chat, but we'll talk a little bit now about the CPS side of things. Laura or Amber, take it
Sure.
away.
Sure, I'll take it away. So we would be processing any of your professional charges. So just to step back of what that is there will be a facility fee, like for the technical part of your, let's say, your CT scan, and then there is the read that the radiologist would do. So we would have that read to bill, and we would process that which way your, whatever way your financial plan would go. And I just want to kind of step back to that, the processing that we do, patients often have maybe they might have 2 trials or 3 trials they're on. So we have to determine which trial the services are supposed to be, review. The review is a very complicated. That's why we really need to understand what trial it's for and understand how the bill is supposed to be processed. So each service stops. So every service, even if they went to the emergency room and unrelated, broke their ankle today, that would stop because it's at that patient level, so they're associated with the trial. So we would have to review that in any case. So be aware of that. If we do ask questions, maybe that you're like, that doesn't have anything to do with the study, then we might ask a question in any case. So if right now there's Qualtrics requirement for the professional charges. So if you have a service that's on your billing grid, so that's important to know what's on your billing grid for your services that are research related. So then if you have one of those services, then you would be responsible to send a Qualtrics form that identifies which way the patient is supposed to be billed. So it shouldn't just say study related, it should say bill to study or bill to patient insurance, right? Because it could be either or. The form is used for all of your professional charges until Encore Financials is fully integrated. And that is, we're still seeing a lot, even if you're in Encore, we're not always seeing the occurrence of the visits and identifying, putting the patient where they're supposed to be on their calendar. So that's really important.
Yeah, I think that's key too, is right, that visit occurring is a really important piece for us as well.
And then that link would be just to the Qualtrics form, which you probably already have. So when you get this presentation, you'll have that. So what we would consider services that you'd want to send a Qualtrics form are those research services that are in Epic. So that would be a physician service, so professional services, or it could be a physician, NP, PA, anybody who's licensed to that can bill in Epic. So it could be other things, not a lot in the hospital setting, but there are some. So those we would need the Qualtrics form for. And if it's performed in freighter space. So there we have here some different settings that are MCW only that wouldn't be in Epic. So that's one of those identifiers for you too. So it excludes those services if it's in an MCW research space or if you're doing it in sponsor provided equipment that wouldn't be in Epic.
Mm-hmm. And that can be sometimes challenging too, right, Laura, to
To
know.
know.
And so, when in doubt, ask.
Correct.
So key takeaways, right? Standard of care isn't always the easiest to discern in the context of a qualifying clinical trial. But we want to make sure that you know that it could be more than what you would normally do for a patient outside of the context of a qualifying clinical trial. And that's okay, because if it's clinically relevant, medically necessary care that would typically be billable to patient insurance because of whatever that safety need is, then those regulations support billing those things in the context of a qualifying clinical trial as well. And so our institutional preference is to bill as standard of care in a qualifying clinical trial wherever possible, especially for those high dollar services that we highlighted earlier, your hospitalization, your surgical events, your imaging, your biopsies. If those things are billable, we're gonna likely encourage you, if you're identifying that your sponsor wants to cover the costs and we believe that it is billable, we'll want to have that conversation about that particular service and investigate if there is any opportunity to put those funds elsewhere within your budget so that we can bill for that service as routine care. Education to this work that we do, while you don't need to know and be the subject matter experts of everything about coverage analysis behind the scenes, it is important to have some basic billing compliance understandings and know, right, what is our Freighter and MCW institutional workflow, because that's going to help you give us the information that we need on the front end, collaborate with us on building that grid and establishing that financial and operational plan, and then managing those things accurately on the back end, right? You'll know when to occur your visits, that it's accurate, what boxes to check or uncheck in Encore financials, what invoices you're expecting to receive from Freighter, and all of those pieces are critical to your work and your understanding of how you interact with your patient participants. And so any education that we can provide for your departments, even individually like this, don't hesitate to reach out to OCRIC or CPS. We're more than willing to do those mini education sessions with your teams, especially let's say you got an influx of new, coordinators and you want to get all of them together. If you've got staff meetings, we'll come quarterly or we'll come once a year just to say, hey, freebie OCRIC CPS questions day, right? We're not the enemy. We actually just want to all be on the same page to support and collaborate, because that's what's going to be the most efficient for activation. We have the same goal that you guys have. We want those studies open and off our plates just as fast as you do, but we can't do it without a good partnership. So be sure to, ask us your questions, take this education back to your teams, learn a little bit about those basic billing compliance workflows, so that, you can be better suited to interact with us when we're working on the finer details of that work.
I love your when in doubt, talk it out.
When in doubt, talk it out. That's right. And here are just, resources, right? So we've got lots of different ways for you to find out information. We've got a very robust website out there on freighter.com that outlines kind of all of the information that you would ever need to know about conducting research at Freighter. And our program email, our phone, you guys know oftentimes who I am or who your nurse consultants are. So don't ever hesitate to reach out if you have a question. And I know, our colleagues from CPS feel the same. They would much rather have you come to them early, ask the question and not struggle. No question is a stupid question. It's just when in doubt, talk it out. It's just the best way. And don't struggle over email, just pick up that phone. So thank you guys, really appreciate, your time today. And, I think we have one more slide, a couple more slides. So, did you wanna, step in here? I can.
Sure.
I
I
can
mean,
talk
have
to
to,
you.
whatever, yeah. Come on up.
Come on up, then people can see you.
Thank you.
Yeah.
Jen put a comment in the chat too. You
Oh,
want
okay.
to call that out?
Okay.
Do you see Jen's, comment?
Yeah, so Jen's just reminding that there is a city optional module for this clinical trial billing compliance, so that anyone can take in city.
Yes.
So we'll do to everyone.
And that module is actually very helpful, and it's from Kelly Willenberg, who is the industry expert and who trained and guided OCRIC to build our program back in 2008. And so it's really kind of helpful reinforcement of the conversation that we just had.
I agree. That was great. I did it recently. I was impressed. Oh, good. Hi, I just wanted to say a couple different things about research billing at Children's. That was a great presentation. All of you, it was fantastic. The principles, all of that, obviously not different, but process is different at Children's for a couple reasons that people are aware of. So hopefully there's some pediatric coordinators here. In terms of basic process, we kind of follow the same philosophy of having a grid, a billing plan, which identifies research versus standard of care, the who, what, where, when, why, of the study activities. If you hadn't gotten recent communication, Diane Bauer is retired, so our new compliance program manager is Maria. And she might still be on the call, so if she wants to address any questions too, that would be great. But she's going to want to see your protocol, the clinical trial agreement with the sponsor budget, draft is fine, your billing plan, which again is that grid, which identifies all those things. The access to that is on the shared drive. The template is there. You'll be working with your sponsor and the PI to really clarify those standard of care versus research activities. That's kind of the part that's a little bit different between what Oak Brook's doing and what's being done at the division level and with the sponsor. If you do know the CPT codes, then that's going to be on your billing plan. But if you don't know them, compliance is going to be confirming the CPT codes as well as giving you the charges. And because Children's Hospital is billing both the hospital and the professional fees out of Epic, it's different teams, but it's still part of Children's Finance. The compliance review process is going to be giving you the hospital and the professional charges for all your study related activities that are going to be billable to research. You're going to submit that to research compliance, and I can't say it enough. Please submit this before IRB eBridge submission because it's going to stop there first, and there's just a lot of work that has to happen before it gets to the IRB to clarify that in terms of local context. If the billing plan hasn't been hammered out, then it's going to probably impact how things are described in your protocol and your consent form and things like that. So doing that work before is essential. And then claims management is also different at Children's. The part that's the same is you're going to linking those encounters with the study record. The patient has to be enrolled in the study in Epic in order to have the process work as well. So you want to make sure that you're linking all of those encounters associated with it. And then after the visit, there is a charge notification form that is sent to a shared email address, research billing. And on that, you're going to be, there's a template that obviously has all the study specific information, the patient information, and then a place to indicate all of the CPT codes and the charge descriptions for the hospital, and then a section for all of the CPT codes and charge descriptions for the professional fees. They need to be the CPT codes and the charge descriptions as they're identified on your billing plan, which corresponds to how they're billed out in Epic as well. After you've sent in the charge notification, we still advise as a best practice, you should be reviewing in the hospital account maintenance that the charges, nothing is there that isn't supposed to be. Everything that you expected is there for both professional transactions as well as the hospital billing. Bearing in mind that the professional billing stays in a pending status a little bit longer than hospital billing, but you can still see that the charges that are going to drop on the professional side after the visit. Invoicing, the invoices are going to come from Children's Finance. It comes from Mary. She'll send you all of the statements. It comes per study per month, similar to on the adult side. It's charges for 1 month are going to get invoiced the following month. Your statement will include both the hospital and the professional fees separated into different guarantor accounts, hospital accounts for those charges. Those are submitted by the study team. You can submit them as a one-time payment. You can set up a standing PO and things like that, but you'll want to work that out with Colleen if you're going to be setting up a standing PO. And then what's important too is that because there's hospital charges and professional charges, and each will have a separate account on your statement, you have to apply your payment to the account where the bill is occurring. It's kind of like putting down 2 credit cards for the same, restaurant bill. You got to make sure you're paying the hospital, the charges related to the hospital, and paying the practice for the professional fees. So any questions about that? I'm happy to always help, walk through things, do training, as well as Maria and Jeff can do that too. And so there's kind of our primary contacts. Maria is, our program manager for compliance. Right, obviously the person that's going to be working with you on all these things. Jeff Crawford is our research operations specialist in the TRU. Jeff provides a lot of the research training and navigation Epic support. So if you have questions about linking studies and all the things related to that, Jeff is going to be the person to do that. And if you're not sure who to go to or just have other questions, that's my job. So I'm happy to field any questions that you're just not sure what to do and where to get started. So reach out to me for that. Someone else had maybe one more. Is that you, Amit? You wanted to talk about this?
The
Sure.
trial
Oh.
innovation network.
Yeah, well, yeah, it's a separate topic,
Okay.
but just opening up if there are any other questions, comments, and this forum is also to share your experiences as well. If you guys have encountered any specific scenarios that are uncommon and you'd like to share, that's most welcome as well.
I think Teresa did say one thing that I just want to highlight too for us is, we also advise from Okrick and CPS. Don't submit to the IRB until your coverage analysis and budget are at least done. Because then you won't run the risk of having to deal with any amendments or other challenges on the back end because you didn't interpret that financial component correctly. And so, your ICF language, all those things, you can get it ready, right? You can work to get yourself prepped, but you really want to make sure you have a good understanding of what that financial plan is going to be before you go ahead and submit all that documentation saying this is what the financial plan is going to be and get that approval, because we won't institutionally approve your project if there's not alignment in those costs, specifically with those costs. So thank you for bringing that up. Yeah.
Yep.
Could you go to the next slide, please? All right, we'll then end up with just as informational. The Trial Innovation Network is funded by the NIH, it's operated by the NIH, and they have these really good seminars that are hosted across the country. They are webinars. So this is just information. You can find this information on our website too. They have all sorts of topics, and it's really interesting speakers they usually get. So try to sign up if it's relevant and if you're interested. Again, otherwise, no other questions, any final comments? All right, and we can wrap this up. Thank you everyone for joining in and hope to
you.
see you next month as well.
Yeah. Thanks, everybody.
Thank you.